So we have a 2-year-old boy presenting with a 10-day history of fever, bloodshot eyes, a sore throat, and rash. He was given amoxicillin but made no difference. There is no history of travel or contact with infection. On examination, temperature 39.8, which is quite high. Bilateral conjunctivitis, erythematous, cracked lips, and erythematous pharynx. There is maculopapular rash over the trunks. There is cervical lymphadenopathy, but no lymphadenopathy noted elsewhere. Chest is clear with cardiovascular and abdominal examination being normal. So as usual, I'll give you 5 seconds to pause the video and come back with your diagnosis, please. Okay, so the correct answer is Kawasaki disease. Okay, so let's just work this out together. So the option A, acute lymphoblastic leukemia. So yes, there are some features that can suggest lymphoblastic leukemia, such as the uh, like cervical lymphadenopathy. But then, would we really see bilateral conjunctivitis or erythematous, cracked lips and pharynx, or rashes? Don't think so. So we can rule that one out. And for the sake of exam, they might give you a bit more information about blood film or even family history as well. Reactive arthritis. Now, I do understand why some of you would go for this option, because in reactive arthritis, we do actually have uh, conjunctivitis, bilateral conjunctivitis. Uh, but then really, reactive arthritis I wouldn't say it would present in someone who's of this age, and it's mostly a disease of the young, and we would also have to see arthritis, like uh, pain in the articulations, uh, but then we're not told of any of these. So, and also it would really say that the patient's been sexually active, or they've had some food poisoning and abdominal pain. So there must be a trigger for this. So we can easily rule that one out. Chickenpox. So yes, chickenpox does come with some rashes, especially over the trunk. But then the rash that is described in chickenpox is vesicular. But then we're told here in our case that the rash is maculopapular. So we can easily rule that one out. Now, scarlet fever, this is an interesting one, because yes, scarlet fever and uh, Kawasaki disease, they do overlap quite a lot. Uh, but then the rash, oral and peripheral changes of scarlet fever are similar to Kawasaki disease, but the lymphadenopathy is more extensive and conjunctivitis is not seen in Kawasaki disease. The rash in scarlet fever normally begins on the day 2 to 3 of the illness, and remember that that is very important. And normally that rash starts in the groin or axilla and rapidly spreads to the trunk, arms, and legs. Okay, now going through the blood result, we do have significantly high white blood cell count, neutrophils, and platelets. Okay, so platelets are uh, slightly raised, so bear that in mind, because I'll explain that a bit more in details. We do see that the infection or inflammation markers are being raised, namely the CRP and ESR. Okay, The kidney functions, they remain normal, but then in scarlet fever, these two can rise, uh, but then that happens during the course of, so like after 2 to 3 days. But then in our case, these are all normal. So let's learn a bit more about Kawasaki disease. So the clinical features are prolonged fever. It can even be more than 10 days. So as a rule of thumb, any uh, young patients presenting with prolonged fever, you should really suspect Kawasaki disease until proven otherwise. The conjunctivitis seen in Kawasaki disease is described as non-purulent. There's cervical lymphadenopathy, skin rash that we talked about, erythema and swelling of the hands and feet. That's a key piece of information as well, so bear that in mind. And these swellings are they undergo desquamation, especially after a week later. So remember that one as well. Erythema of the oral and pharyngeal mucosa. So, or sometimes they refer to these two as strawberry tongue. Okay, but then remember that strawberry tongue is also seen in scarlet fever. So remember that, please. In terms of pathology, Kawasaki disease is a vasculitic disease, and it happens mostly in 80% of cases in people who are under the age of 5 years old. And main worry is a coronary artery aneurysm that can lead to myocardial infarction and even death. So, as a good doctor in your practice, if you come across that is treated as an emergency, okay. Investigations is a clinical judgment. Is clinically judged. Sorry, and again, if you suspect that, in terms of management, you definitely start with infusion of immunoglobulins at diagnosis. Okay, that is very important because what you don't want is coronary artery aneurysm, and you also start them on high dose. Okay, why high dose aspirin? Why? Because obviously it's a vasculitic disease along with a slight raise in thrombocytes, so you're more prone to get thrombosis. Okay, so these two are very important. As a good doctor, you have to start these straight away. Now, in terms of prognosis, it is related to the cardiac complications that we spoke about, mainly the coronary artery aneurysm. The risk of cardiac complications if treatment with immunoglobulins was commenced within 10 days of diagnosis is less than 10%. Okay, and also just to add this and to finish off, Kawasaki disease is one of the few scenarios where aspirin is allowed in children, because remember, aspirin is usually avoided due to Reyes syndrome. Okay, let me just write that down. Reyes syndrome. Okay, and it's a syndrome that is actually rare, but then it's a disorder that affects all organs of the body, but is most harmful to the brain and the liver, causing an acute increase of pressure within the brain and often massive accumulation of fat in the liver and other organs. Okay, so hope that was useful.